will discuss later on. So once again, I will restrict myself to today's talk mainly on the conservative management of AUB. See how the conservative managements have come to oak. The quest for less invasive alternates to hysterectomy in women with menorrhagia, but in whom uterine pathology is not essential to take out the uterus, has made the scientists to think how to control the bleeding. And their observation, Asherman syndrome patients are not having any bleeding and they are becoming amenorrheic. So some of the innovative thinking doctors started having, why not we create Asherman-like syndrome iatrogenically? So in this method, they started they developed various irritants and injected into the uterine cavity, like chemicals like paraformaldehyde, methyl cyanacrylate, or quinacrine hydrochloride. They injected into the uterine cavity to create a Asherman-like syndrome, thereby achieving amenorrhea. Needless to say, all these carried a considerable risk and they have had a lot of complication and with the limited success. But in 1981, Goldrath and colleagues first described hysteroscopic photovaporization of the endometrium using neodymium YAG laser, and the results were very successful. The ablation techniques are divided into three types, three generations: first generation, second and third generation. In the first generation, we have laser coagulation, transcervical resection of endometrium, and roller ball ablation technique performed through hysteroscopically. So concomitant procedures: hysteroscopic myomectomy in patients who are having submucosal leiomyomas, and sometimes combined TCRE with ablation technique, and there are various studies to compare these results. This we will discuss. For doing transcervical resection of endometrium, you need to have good hysteroscopic resectoscopes. Nowadays, thanks to the imaging modalities, we have various high resolution cameras, imaging systems, and most important is the energy sources. Last time, some of the doctors were asking about, tell more details of transcervical resection of endometrium. To perform a transcervical resection of endometrium, first, as I always tell, to manage anything, you should start with the proper history taking, a detailed clinical examination, a relevant investigation, then your procedure should be planned. The history is very relevant pertaining to the age. You should take a detailed history, the drugs she is taking, whether there are any associated systemic diseases, coagulation disorder, everything you have to take a detailed history. Then a thorough clinical examination, starting from general examination, breast examination, parabdomen examination, a proper speculum examination to rule out the local pathology of having any cervical polyp or any other erosion, then do a bimanual examination. Apart from relevant blood investigation, a proper transvaginal high resolution ultrasound. Once it has ruled out all local pathologies and the endometrium is thick and you have an endometrial biopsy which has excluded malignancy, then comes transcervical resection of endometrium. In transcervical resection of endometrium, after dilatation of the cervix, there are two methods. Either first you can do a hysteroscopy and see the pathology, or if you have good experience, you can directly use the receptoscope, which also does the diagnostic hysteroscopy job. In the same sitting, you can resect the transcervically the endometrium. When you do transcervical resection of endometrium, before you start resecting, you have to visualize the entire uterocervical canal See both the osteas and